Welcome to another episode of Veterinary Journal Club, Vet Books. It's Vet Books. Vet Books round 8, chapter 7.
Chapter 7.
Yep. Chapter 7 of Small Animal Critical Care Medicine.
What book have we been doing for the last couple months?
You know, I didn't want to get it wrong. Edited by Silverstein and Hopper. During my residency, we called it the Hopperstein book.
Hopperstein.
Yeah.
I think I've heard you say that before.
Oh, yeah, I've definitely referred to it as a Hopperstein book. I don't know if they would find that humorous or really annoying. I could ask. I'll ask next time I talk to one of them. Okay, so chapter 7 is on multiple organ dysfunction syndrome, or MODS. MODS. And this chapter...
like video game mods.
What's the video game?
Video game mods.
Oh, that's right. You said something about that.
Yeah, it's when they changed
the modifications. Yeah. It's short for modification. No, this is an acronym. And this chapter, we'll start with that since I forgot it last time, was co-written by Rob Goggs and Dan Lewis. You know Dan Lewis?
Oh, yeah, I do.
Yeah. From all the years we were on the exam committee together. Mm-hmm. So
it's a small world. It
is a very small world when you know these people.
Yeah.
Actually, Rob was the chair of the exam committee he's the one who recruited me to join the exam committee. So he was the chair of it the first year I was on. And so, yeah, I was on it with him for 2 years. Any rate.
What chapter did you write in this book?
None. Yeah, no, I did not get invited to write any chapters for this book.
Makes sense.
That's way harsh. Anyhow, MODS. So MODS fittingly follows the SIRS chapter. This is the acronym section of the textbook.
Like MOD from The Impossibles?
No, that's a different acronym. MAUD for MOD. MAUDE. Okay, what do you think multiple organ dysfunction syndrome is?
I think it's when you have two organs that are doing the wrong thing. Two or more.
What do you mean the wrong thing?
Like you're in kidney failure and heart failure.
Yeah, that's it. There you go. 2 or more organs that are failing.
Yes.
That's essentially.
Wait, I got a sound. I got to get to it.
Don't do the wrong one. Don't do the wrong one.
Oh. Got it right.
It took a really long time to give you that positive
I have a limited
feedback.
soundboard.
Yeah. All right.
Sorry.
So, I mean, essentially, it's not exactly like you could have a patient that, for a variety of reasons, develops heart failure, like a degenerative disease. They have, something that would be common in dogs would be like mitral valve disease. That older small breed dogs often develop this, but it's also not uncommon for older small breed dogs to maybe develop secondary, or not secondary, but just like kidney dysfunction, kidney failure, and that wouldn't necessarily fit the criteria for MODS, because it also has to arise from some these are happening at the same time secondary, because remember this is a syndrome.
Oh, it's secondary. Okay.
Right. So this is
one organ fails and it causes another organ to fail?
Not necessarily. So this could be after trauma or with sepsis. So sepsis isn't an organ failing. That is an organism failing, essentially. Mm-hmm. And so you have some extreme inflammatory insult, SIRS. And then, so SIRS and MODS often go together. You have a patient with SIRS, and then if they have 2 or more organs that start to fail, now you have MODS with your SIRS. SIRS and MODS. SIRS.
What about like an old patient that it's old and its kidneys are failing, but then it also has a heart problem?
And that's what I was trying to say. That doesn't necessarily
not
fit.
Necessarily MODS.
No, that's just like bad luck,
Right.
Or
so they need to be like...
That needs to be secondary to... So there needs to be a problem.
If you treated the problem, it would fix both of them.
Right. Exactly. Yeah. So these are potentially reversible organ dysfunction. Yeah. That's the other thing is they frequently aren't reversible and that the patient goes on and dies. But like if you were to stop the underlying problem, the organs that are failing could recover. Mm-hmm. So it's like the heart isn't working, but it's not necessarily like in heart disease or heart failure, like I was suggesting earlier, you have mitral valve disease. So that's like a chronic progressive condition that the animal has. This is something different. This is like, oh, the heart isn't functioning right now because it's not getting enough oxygen. And so it's got arrhythmias, or maybe it's the contractility of the heart isn't very good. But if we fix the underlying problem that is creating the conditions that make it so the heart can't do its job very well, then we can reverse that and go back. So MODS is occurring because you like, so you work for a company and they bring in like a new management system and they're going to revamp everything and everybody starts working worse for a while. Like this is not working. Everything you guys are changing. You're creating conditions that are toxic. It's a toxic work environment. And then when you fire that management system and go back to the way it was, everybody can go back to working effectively again. How's that for an analogy? You don't like that one?
Yeah. I was going to ask, is that what about, so let's say you get like a tree branch through your chest and it stabs your lung. And so now you can't breathe very well because your lung's been stabbed, but then you're also bleeding out. So your heart's having trouble. Would that be MODS? Because you just have to like sew up the...
Probably not yet. Because at this point, the heart isn't failing. It's not functioning improperly. Like from the example you've given, it's just in shock. So the heart's actually doing a good job keeping you alive. Yeah. So you're probably going to have a high heart rate. You're going to be tachycardic. Your blood vessels are going to respond to the blood loss. Your lungs are damaged, but that's not, again, that's the primary insult. So I would not consider that MODS at that point.
So what if you're hit by a car?
Yes.
And your spleen ruptures and you get lung damage?
Yeah, those are all part of the primary injury. Yeah. So again, I wouldn't call that MODS. Now, let's say you get hit by a car.
I don't even know if dogs have spleens, by the way.
They do.
Yes.
Good job. You get hit by you have to have heard me talk about
splenectomies.
Spleens. Yeah. Good job. So you get hit by a car, your dog gets hit by a car and it suffers like damage to all, the organs, lots of bruising and things like that. And then a couple of days later, the patient starts to develop arrhythmias or develops what's called ARDS, a different acronym, acute respiratory distress syndrome. That might even be the next chapter. Hang on, it might be the next chapter. Nope, darn. I was hoping it would be. And then it also develops another syndrome called DIC. You've heard me talk about yeah, we've definitely talked about that one on the show. But like it's all the consequences of the severe inflammation.
So MODS is not going to be like a sudden onset thing.
No.
It takes time.
Okay. Yeah. So again, it's secondary. It's after some primary injury or insult or disease. So an animal gets pneumonia and so its lungs aren't working because of the pneumonia. But then a couple days later, its kidneys start to fail and its liver starts to fail because it's got sepsis from the pneumonia. So that would be MODS, if that makes sense. Okay. So yeah. They have a lot of like tables and charts in this. This is one of the longest chapters, I think, in the whole book.
Oh yeah, because I was thinking you were kind of done describing it.
Well, yeah, I'm just describing it. This is like 9 pages because they go into like specific details for like which. Well, they go into the pathophysiology, like how does it develop or how is it theorized that it's developed? And so they've got, headings under the pathophysiology of the immune system being dysregulated, which is also something we see in sepsis specifically, the coagulation system being dysregulated. And then they have a whole heading on mitochondria and how the mitochondria play a role in this because mitochondria are
the powerhouse of the cell.
The powerhouse of the cell. But if they're not working properly, the cell dies. Right. So mitochondrial dysfunction means the cells can't produce the energy they need and then they start to die. And then the GI tract, so it's just specific organ systems, like what is happening at this level, what is happening. So they get into a decent amount of detail for each of these. And then you have to look at like criteria for defining this because like you said it's a bit wishy-washy because it's a syndrome and we've talked about that a lot lately, that syndromes make it kind of hard. It's not like, oh, you do this test and if you get,
they're just kind of helpers. It's like if you have this you should watch out for these things. Right, exactly.
It's a way to sort of organize your thoughts, be like, oh, you should be worried about X, Y, and Z. The other thing that they talk about in this chapter, which I'm pretty sure this could have been in the first edition, but I think there might be something in this textbook as well, the second edition, on just like severity scores. So one of the things that's really commonly used in human medicine, probably more than definitely more than in veterinary medicine, but like they'll have severity scores for different disease states, or sometimes just people talk about the SOFA score. So the sequential organ failure score criteria. And or the SOFA is sequential organ failure assessment. And then you have SOFA scores. And what that's meant to do is try to stratify patients. One, to identify patients that are in like serious trouble and we need to like divert maybe some resources to them. But probably even more important than that is being able to stratify patients for research purposes. So if you wanted to do a study and to say, okay, patients that develop MODS, and these are the criteria we have for MODS, if we do this intervention, it improves outcome. But when you're doing these types of, prospective scientific studies, you want to be able to look back and be like, well, was it just random chance that, patients in group A were just more severely affected than patients in group B? And so one of the ways... Because
you can have a MODS patient that's like not that bad off,
right?
But you can have one that's
barely
on
meet the
death's door.
Criteria, exactly. And so if you apply the treatment that you're testing to both patients, 5
organs that are down, that's way worse.
Exactly. And so that's where things like SOFA scores come in handy. So that overall, when you look at this group of patients and that group of patients, you can say, oh, or you can even narrow things further and you say we're only enrolling patients that have a SOFA score in this range, so that we're comparing relatively similar groups. And it's not going to be that like, oh, well, these patients did better just by random chance. And so it makes it a little harder for people to critique your results if you've done something like that. Like, hey, we've tried to establish that the patients in both groups were similar severity, that kind of thing. And, so it's just, but there's a bunch of different scores. The SOFA score is a pretty commonly used one. In animals, there's the Apple scores. Have you heard me? I think you've heard me talk about the Apple scores.
I think I usually hear you say that you don't like scores.
It's not that I have a problem with scores. I have a problem with people using the scores inappropriately. So it's dangerous in veterinary medicine because we euthanize patients.
Right.
And so if I use a score...
And that determines the outcome.
Exactly. And so if I use a score that says, oh, this patient is going to die, and then we euthanize it, that becomes a self-fulfilling prophecy. And so if scores, you have a scale and it's out of 20 and we say, okay, animals that have a score greater than 15 are going to die. And so then we euthanize every patient with a score greater than 15, then what? There are patients in there we maybe could have saved. And so when people use a score that is meant to be assessing a population to apply to an individual, they do it wrong. And a lot of people make that mistake, and they make recommendations for
cat problem. Yeah. It's a probability.
Yeah,
exactly. For one thing, there is no probability.
Exactly. You can't apply probability statistics to an individual. This individual is either going to survive or it's going to die. And this score cannot tell you whether or not this patient will survive. And if 75% of patients with a score greater than 15 die, that's 24% of patients that don't. 1 in every 4 patients. I mean, and that's a terrible mortality rate, right? Like 75% of patients, that's a high mortality rate. But 1 in 4 patients that you see is going to survive unless you euthanize 100% of them. And then so anyway, that's why, sorry, you started this. I wasn't going to go down there, but I do really get upset because people want to use that to prognosticate for an individual, and that is not how they are meant to be used. And it is quite a pet peeve of mine. So we'll talk about that. Yeah, have we already talked about this on a show? I feel like
I don't think you have.
Oh, well, maybe we need to have that.
I think
you've heard me
you
harp
into
on
it every now and then.
Yeah.
I know it makes Bobbi mad, so I like to bring it up.
Yeah. He's kind of mean like that. But it's an important point.
Yeah. Probability does not apply to populations of 1.
Exactly right. So I can say this now because I'm no longer on the exam committee for DACVECC, but I made sure to get questions like that on the exam for several years. I was like, this is important and people need to know this. And so I wrote a question. Sorry. I guess if you're a diplomat now, it worked out for you one way or the other.
But if you're not,
whether you got this question right or wrong? I mean, I don't know if they'll still be on the exam because I was definitely a proponent of, hey, we need to put these scores on here and ask the candidates questions about what is an appropriate way to use them, because there are a lot of studies out there that people, and I get it.
It seems like research is the most appropriate thing.
Yes, that's when it should be used for those kind of scares, so that you can decide like this was appropriate. But people are always publishing studies about prognostic indicators for. I mean, that's so common to find prognostic indicators. And it just, I get really frustrated because people are going to use it wrong. Mm-hmm. They don't understand.
I think we've seen a couple papers where people used euthanized patients as a negative outcome.
Yeah. And I'm like, you can't do that.
A euthanized patient has no outcome.
Right.
It's essentially throwing it out.
Exactly. We have to eliminate that because if you euthanized it,
you don't know what happened.
We have no idea what was going to happen. And the hard part is like, I'm not saying we shouldn't be euthanizing patients. That is not what I'm saying at all. I think that I'm really grateful that that's an option that we have for our patients. However, when you're doing research, you have to consider that
research is about the outcome of a disease.
Exactly. It's not about the outcome of whether now, if you were doing a study about what are the factors that determine when clients euthanize their pets, okay, yes, you should include those patients because you're asking a different question. But if you're trying to sort out mortality rates, you absolutely should not include patients that are euthanized. You can't. And I've reviewed papers.
Playing like the first half of any sort of sport game and being like, oh, that's the score, so we're done. We don't need to do the second half.
There's no point in continuing because we already know. No.
The higher ranked team is in the lead, so they'll probably win.
Yeah, that's true. They probably will. But we don't know yet because we haven't finished the second half of the darn game. Yeah. Anyhow, you did it even more. You gave me even more. So which score to use is one of the subheadings in this chapter, and my answer is none of them. Unless you are doing a research project. Mm-hmm. But if you use them to decide whether or not you should euthanize a patient or continue treating, you're doing it
seems
wrong.
like you should do the normal thing if you're trying to decide euthanize, but just kind of look and see
that's the problem. We already know that. And it's true. Like patients that are doing worse are more likely to die.
Right.
Oh, really? That's what... That's kind of the sarcastic response I have to every prognostic indicator study is sicker patients are more likely to die. What? You've got to be kidding me. No one saw that one coming. Okay, that's going to be a future show that we do. We're going to talk about
sicker patients.
We're going to talk about prognostic studies, and then we're going to talk about the surprise test. Have I talked to you about the surprise test? We're not going to talk about it.
You did tell me about it, but I forgot about it.
Okay, cool. Surprise. We'll talk about it next time. It's pretty cool. But does also kind of go into a little bit of why I don't think we should use prognostic scores for an individual patient. I have to stress that. Like there are plenty of times. And so collecting these scores so that one day you can do a retrospective study, or again, if part of a prospective study you're doing, super important, really useful, really nice. But if it's helping you make decisions or helping you in how you counsel a client on whether or not to euthanize a patient, super inappropriate. You weren't listening to me for the last little bit because you were thinking about what the surprise test was.
Yeah.
Yeah. Well, don't say anything. We'll save it for another show. Maybe somebody will go looking it up in the meantime.
Careful Googling that.
I think you'll be fine.
I don't know if you have your filters off.
Okay. Yeah. What else? So this chapter has a lot of little nuggets, which I think is fun. I don't know why you're grinning at me about that.
You just call them little nuggets.
Yeah. Little like, here's a cool little nugget about this thing, or
be a little more specific.
They have brief paragraphs of lots of different subheadings to be like, here, let me tell you just a little bit about the lungs in MODS, or let me tell you a little bit about the kidneys in MODS, and the heart and the GI tract and all that kind of stuff. So they're all lots of little short, easy to digest. Stop. I'm not going to say it again. Calm down. A little bit on corticosteroid use, like a very short paragraph on novel therapeutic approaches, things like that. So it's a difficult chapter to kind of summarize because there's lots of little things that all together create the entirety of the chapter. But it is one of the longest chapters in the book, and they've got about 1 million resources, references. Let's see. For this 9-page book chapter, 156 references.
Wow.
Yeah.
Easy, Dan.
You guys weren't messing around. I know. Calm down, Rob. Dan. No, it's pretty good. But like that's the thing. Each little brief paragraph.
Dan and Rob, is that a band?
Dan Rob?
Dan and Rob?
I don't know. Okay, Google that. Do you have your phone?
Yeah. All right. You keep talking about vet stuff. I'll figure this out.
Well, now I'm curious about Dan and Rob.
I'll get back to
you. They talk a little bit about some more. This is just an acronym, jam-packed acronym chapter. So if you really
Dan and Shay,
yeah, that's so close.
Sorry, Rob.
So close. All right. I think I've gone off on the rails a little bit here. Is it time for the backwards game?
You don't have anything else on MODS?
No.
That's how kind of felt when you first you were just talking about it being a long chapter, and then you first described it. I was like, that seems like it.
Yeah. No,
What
it's
are
a
the
long chapter
things-
because they go into more detail.
So why do you need to care about mods, like when you're in the clinic? Is it just so you don't give like a medication to help one thing and it screws the other
I think
up?
it's more like when you have, here's how I think you should be using this. If you have a patient who's really sick and this is the area that's a problem, don't forget about everywhere else, because you can't just treat the lungs and think that the patient will get better. Because if you focus so much on one organ system, the one that's primarily injured, and you forget to take care of the rest of the body, it'll bite you in the butt.
Yeah.
I think that's kind of the main point, is that you can have a problem in one part of the body and then all of the inflammation, the cytokines, the process itself, the healing process, can have knock-on effects in other parts of the body. And if you're not on the lookout for that, you're not supporting that, you're not trying to prevent it when you can, you're going to run into problems. So I think it's just remembering that you're treating the organism as a whole rather than a specific, I'm just treating kidney failure. It's like, no, you have to keep an eye out for everything else.
Like,
so I think that's the point.
when you have a patient in the hospital, you think you're treating it for one thing, but even if you're just doing one thing, you're still feeding it, walking it, giving it water. Like you have to do all these other things.
But also the treatments that you're giving to help one organ system might be harmful for a different one.
Yeah.
Like the things we do.
Yeah, I think you talk about the kidneys and the heart's why I bring it. Like if kidneys need water when they're going bad, but the heart doesn't need.
Well, the treatment for heart failure is dehydration, and dehydration is bad for the kidneys.
Yeah.
And so rehydrating a patient with heart failure makes the heart work. So when they are both failing, they don't play well together. But it turns out giving too much water to the kidneys is also bad.
Yeah.
But yeah.
Is there any others that like kind of play against each other? Where the treatment is harmful to another one?
Too much fluid is bad for all of them, but some organs tolerate that better than others. I would say the GI tract is going to be pretty sensitive. So you're like, the kidneys need antibiotics, and the GI tract is like, but all the bacteria live here, and you're going to screw me up by treating this with antibiotics. So antibiotics for antibiotics.
Could you do like localized antibiotics for a kidney?
No, but it's a really great idea. You can do localized like topical antibiotics for certain things.
You can't inject them in like pow.
Well, I shouldn't say that. There are, if you had like, kind of, but not easily or not routinely is the short version. So you can instill like in the bladder, you could probably instill antibiotics. I don't know if anybody does that routinely. Probably not. I can't think of like a specific syndrome, but like every time you treat one system, now the kidneys are supposed to be sterile, right? So if you give antibiotics and you kill off all the bacteria in the kidneys, sweet. Same thing. The lungs, not exactly sterile, but there shouldn't be a bunch of bacteria. The heart should be sterile. The brain, the CNS should be sterile. The GI tract definitely shouldn't be sterile. So you're going to have definitely knock-on effects if you're trying to sterilize the rest of the body and the GI tract becomes affected. What's up, motor? Every time you do one thing that might be helpful for this system could potentially be harmful for another one. So, you got to be mindful of that. I think that's the main take home of the chapter.
Pay attention.
Yeah. Essentially, understand physiology
of what you're doing.
Understand the physiology. I think just knowing physiology is super duper important. Anyway.
All right.
Time to play a game.
Do we have today? Eat for it.
Wait, what? Oh.
It's the backwards game.
I just realized that we should say the backwards game and then play it backwards as part of the title.
Oh, yeah, I can do that.
Right?
Not now, but next
time.
time.
And it's too late now, but that would have been cool. So you picked some words from this chapter that you've said backwards, and I now have to hear them backwards. Oh, yeah, I've got to use this thing.
Yeah,
that's right. I forgot about this. Okay, so I push play when I go to record.
No, you push record.
Oh, that makes more sense. Okay.
And then you'll record it, and then...
Do I have to push stop after I hit record?
Yeah.
Okay.
After you're done saying it.
I have to hold it real close to my face?
No, not that.
Where I'm at is good?
Oh, yeah, I think it...
Or is it? Okay.
You'll be good.
Okay.
All right, so the first word is mitochondria.
And let's hear it backwards.
Let's hear it backwards.
You're not what I'm...
That's mitochondria.
You're not what I'm...
Okay, I'm ready.
All right, go.
Ayunakbaram.
All right, you ready to hear it?
Oh, you can... Don't you have to do it backwards?
Yeah, you press play.
Oh, okay. I'm ready.
Go for it.
Mitochondria.
Mitochondria, that's really good.
Yes.
Do it again.
Yeah. Mitochondria. I just have a bit of an accent. That was amazing. Okay, if I hit record, it'll automatically record over the last one.
Yeah, it will. The next
that was
word
successful.
is, what do we do?
Coagulation?
Coagulation. We had to get rid of one of them because it sounded inappropriate backwards.
It was so inappropriate. Wow, it was amazingly
It's a
inappropriate.
good thing that we screened.
Yeah.
All right. So it was...
Coagulation.
Coagulation. You ready?
I knew what they were forward. Okay, yeah. Ooh, this one's tough.
You good?
No, one more. Nigga, she Alec. That was so bad.
Yeah, I don't know how that one's going to turn
This
out.
is going to be terrible. Okay, you ready?
I'm ready. I can at the end a little bit.
No, that was so bad. One
Do you
more.
want to try again for coagulation?
Okay, sorry. I'm trying not to laugh into the microphone because that was terrible. That was so bad. No, I don't want to try it again. I think it's only going to get worse from there.
Yeah.
Yeah, that one was a fail. Yeah, my first one was good. Mitochondria was good.
Mitochondria was really good.
Okay.
All right. The last one is sofa score.
I think so, yeah.
Sofa score. We'll be able to tell when it's displayed backwards.
I suppose that's true.
What?
Okay, that sounds terrible. One more? Auroxephus?
I don't think that was it.
I don't know, but that's what you were saying. Okay, you ready?
Yeah.
What? That was so much better than I thought it was going to be. Yeah, I get credit for that. Let's play it one more time for those who were laughing too hard to hear it. Sofa. The sofa was good. Sofa. I'm trying to figure out what that accent is that I'm speaking in. I don't know.
The backwards accent?
The backwards accent. Okay, that was good. I needed that little pick me up at the end because I got off in my little soapbox and whew, you got me fired up. So I needed to giggle.
So what's the next chapter?
The next chapter is not an acronym.
What?
The next chapter, chapter 8, is hypotension.
Hypotension.
Bum, bum, bum.
It's not hypertension?
Nope, that's later. But it's not that. Oh, it is the next chapter. I thought it'd be a different part. So hypotension. And then the next one is not hypertension. It's hypertensive crisis. So looking ahead. Yeah. So there'll be some good stuff there. All right. That's all we got for today. Hope you enjoyed. Don't use your prognostic indicators to decide whether or not a patient should be euthanized. Thank you very much. And we'll catch you next time.
Bye.
Bye.